What's going on, everybody? It is Mark Jarod, lead faculty and CEO here at Modern Pain Care, where we make you the complete clinician. Coming at you with the next episode of the Modern Pain podcast, and still kind of keeping up with our format where we're going to be sharing some more clinical pearls, some clinical tips and things that Jarod and I have found helpful for us in our journey, and just some clinical concepts that we've also, thought about and found unpacking this stuff helping us a bit in the clinic. So before we get into today's topic, how are you doing, Jarod?
I'm doing good, man. I am back in my office this week. My brother has he has left and he has gone to Germany and made it there safely, and so I am back on a stable internet connection. So looking forward to not having to deal with low quality pixelated face Jarod.
Yeah, you know what? It actually pulled through. Your clubhouse there at your current spot was, it's not, you don't quite have the backdrop that you had. For those of you again listening on the podcast, you'll just have to imagine again a mahogany background with all sorts of knickknacks and such. But good to have you back in your place, and not too long. You're under a year in that place, and you'll be moving on to bigger and better pastures with the new house. So congrats on that. But anyway, before we get talking too much about your housing situation, common question and common thing that we've seen, because I look back to my career, and when I first came out of PT, it was very much I got into this clinic that was very soft tissue related, and it was very much yonda upper lower cross syndrome based reasoning. And because of that, you blasted pecs, and you did deep soft tissue, and you dug into the psoas, and you released the tar out of that thing. And there were episodes where folks had some soft tissue actually injuries, and they're thankfully not from me, but some pretty aggressive stuff. And there's this mechanisms of belief of release and stuff, and basically overall just friggin' painful manual therapy, like just hurt. And yet we still have patients that come in too with like, there's currently, and I always debate whether I should discuss this, but I work alongside some DOs who do FDM, fascial distortion model, which is an interesting model. Let's just leave it at that. Science needs to kind of have its way with it. And hey, if it comes out the other side in a good spot, I'll frickin' do some FDM. But anyway, the regular narratives I hear from patients who come in to the clinic: how did it go with I was crying in the room, or tears were rolling down my eyes. And these are some pretty, what I think stoic, tough individuals. I'm like, good God, can we get past injuring or inflicting massive amounts of pain on people, and then forgetting that, hey, that's probably the mechanism of the effect. Again, we'll talk about it. Maybe it's not that I'm doing some fancy fascial realigning and whatever stuff, again, maybe for another day. That maybe I'm just bombarding the tar out of it, regardless of what fancy model or theory you want to throw at it. That maybe you just strip it down to the simplicity of it. You're frickin' causing pain. And the body, if it has intact endogenous mechanisms, is going to shunt down some. Especially when you put a white coat behind it and a fancy theory and a relationship that you've developed with the patient, you can get away with a lot of painful stuff. But anyway, there's my frustration, because I see it daily, and it's just like a constant internal face palm and eye roll, and I'm just like, good God, can we not? I mean, especially your DOs, for God's sakes, your physicians, we got to do better. But anyway, what's been your response or experience with painful manual therapy, Jarod?
Uh, I guess with when I was in school, I wasn't necessarily taught that you needed to like crush people on soft tissue work, but I was taught that, hey, if somebody's got like limited knee range of motion after a surgery or whatever it is, you need to get in there and you need to do your grade fours like with significant force, and then you need to take up even more slack, and you need to do your grade fours to stretch out the capsule, and then you need to take up more slack, and then you need to do your grade fours like until people are like screaming. Because you got to stretch out that capsule, right? Or if somebody you're ranging somebody's shoulder, you've got to lean your body weight into that and really like make them writhe on the table and like arch like the exorcist. And that's what I came out into clinic doing. And it was like, well, you have soft tissue that is tight, and I'm going to release that soft tissue, and I'm going to use lots of force to do so. Um, and then I kind of got into some instrument assisted stuff, and it was definitely okay, right, to scrape people aggressively and to cause bruising. And it was even like looked at as a good thing to cause bruising and, or, petechia, because that shows that you were releasing that tissue that was restricted and scarred down and adhered and adhesed and whatever. The little adhesion fairies were in there and you got rid of them. So I was definitely not scared to hurt people, with manual therapy. Luckily, at least to my knowledge, I never did any serious damage. But we can get into this in a little bit. I've actually worked with a couple of patients who did have some pretty serious damage, serious issues after aggressive bouts of manual therapy. And I have a laundry list of examples, but I'll probably talk about two in particular that I think really stand out to me.
Yeah, it's coming off of our episode of medial scapular border pain. I have worked with patients who actually suffered a neurologic injury, some peripheral nerve damage from some folks digging into the rhomboids and stuff like that. And again, mistaking some sort of mechanism of releasing and things as like a therapeutic, where, hey, you're just freaking causing pain, and the body's defense mechanisms to get you to kind of more evolutionary, like, hey, this is a really painful thing for you to survive. I'm going to give you a little bit of some pain relief so you can soldier on in life. Maybe we could like leave that mechanism behind in many cases. I mean, we'll talk. Is there ever a place for that? That's a question we'll maybe save for the end. But yeah, that stuff happens. People have painful experiences, and unfortunately, painful experience can be related to an injury inflicted, iatrogenically from PTs, and not just PTs. I've seen it in other professions as well. So, plenty of fingers to be pointed, including, again, I know I've bruised my share of people when I got initially onto the instrumented assisted train, because it was very much, very the new rave, and supposedly I was earlier in my career, didn't really give it a lot of critical analysis and just jumped on the boat initially, and then bruised my share of people and thought it was the right thing to do, because that's kind of what was portrayed from a lot of the folks who were marketing it and things, and patients actually loved it. The bruising kind of leaves marks of like, look what was done. There's visual evidence that I had something done to me, and especially if you strap a nice narrative on it of whatever breaking up, adhesions, and fibroblastic blah blah blahs, and yeah, I mean, you can science it up and make it sound pretty sexy to a patient. Where, wow, that's great, And honestly, I talk to this with students. I'm like, now you take what had just happened in that clinical room where this patient was crying and things, and put it in a context of that just happened from a stranger on the street. And I think you get one person who's getting arrested, the other person, because the context of you're in a medical setting, this is a healing ritual. You ascribe positive meaning to it. It's actually sought out and paid for, and it's just in the other context. You're like, where do I call 911? This is freaking, abuse. I'm getting assaulted at this point. But maybe it's a little extreme. But honestly, I don't think it's off, base for contextual components of what drives a positive response to some of this stuff. But that's just soft tissue. I know you spoke to manual therapy around the knees, and I know you and I have talked about total knees and total joints. Maybe not shoulders as much, but knees definitely. You got to blast that range back, and then same thing with like frozen shoulders. That's another one that I think traditionally was like, you're just gonna. I remember I've had patients tearing up and definitely having episodes of tears, because that's what I thought we had to do. I was operating under the fact that you got to loosen that capsule up and let's get after this thing and go. And it was stretch. And hey, I look at my sadistic ways back, and not purposely. I thought I was doing what was best for the patient. Of course, I think anybody who's doing that and has never, I hopefully, done it to like, I really make this hurt because I don't like this person. It's just, hey, if you operate under mechanisms of like old school ways of doing it and thinking, then you're going to probably think, hey, I'm doing the right thing. And I still have patients, again, with different practitioners, even PTs, DOs, and stuff, where this painful stuff is just like an accepted mode of operation, with little science to support it. So let's talk a little bit about do you want to share any of your stories first before we get into a little bit of the mechanisms of kind of what goes behind? We've already spoke to it a little bit with contextual stuff and different things, but what you want to share any of the stories that you think might help folks out there?
Well, I mean, I think I'll just briefly um, cover one patient that I had maybe about a year ago or so. And this lady was very, very tough, very in the mindset of, it's got to hurt for me to get better. She's avid exerciser, just crushing the gym all the time, but at the same time, like in a big wig type position where working 60 hours a week. So her cup just runneth over like crazy, right? And she had some, hip flexor tightness. She kept being told that she had trigger points in her, like her hip flexor, that were radiating down kind of the front of her thigh, right? You get into a little bit of a lumbar spine type of thing. There's a little bit of lumbar nerve root irritation or whatever, right? And she went and got some really, really aggressive treatment from a chiropractor in town who does some FDM type stuff and some active release type stuff to the psoas. And then she comes back to me the next day, and the entire front of her thigh, all the way down to her medial knee, is numb, completely numb. She can't feel anything. And it took about 6 months for the feeling to come back to the front of her thigh. So we're talking like a pretty serious, femoral nerve or a cutaneous branch of the femoral nerve injury that, I mean, 6 months of pure numbness where she could not feel anything. And then another person, the general low back tightness that the massage therapist was really going to get in there and release the trigger points in the quadratus lumborum. Person had low back tightness for a couple of months, finally went to get an aggressive massage, woke up the next day with a 10 out of 10, searing, unbearable radiculopathy. And, was it getting to the point where it was about to just happen, or was it the forceful, aggressive, pressing, full body weight pressure to an isolated local area that was sensitized, cramming it into extension for long periods of time, or whatever it was, not recognizing the situation that, that's not going to necessarily fix anything. And then this person proceeded to have just an unbearable lumbar radiculopathy for about 4 months that we had to work through, and it all like stemmed from the massage.
Yeah, yeah, and I'm sure others can share stories and different things too. So let's do better with painful stuff. Now, I still think there are currently taught modes of painful manual therapy. I would argue that, like, this comparable sign in the spine where you're finding somebody's pain. I remember having mentors tell me, Jeff Maitland used to say, you got to find the hurt and hurt it, because it's kind of this modulating pain. Now, I understand that response now, and I'd still, like, if you're doing UPA, CPA, say you do a little bit of that in the clinic, what are you doing? You're finding symptoms, comparable signs, symptoms, and you're going in and you're producing nociceptive, you're producing pain, but you're also testing, is your technique providing that positive condition pain modulation, descending noxious inhibitory control, fancy neurobiology, endogenous mechanisms where you get a positive response, because we know that's probably the mechanism of what this painful stuff is doing. It's not realigning or treating humans like cars, all that stuff. We're seeing if we can produce a positive modulation of their symptoms, and if it helps them nudge forward without obviously bringing tears. I'm not a fan of when I produce that pain with some UPA CPAs, because I actually still do it, believe it or not, but it's not tear related. Breathing needs to be on board. It's really gently bumping into symptoms, and then having a very good explanation of not, hey, I'm fixing your car or realigning your fascia or helping things slide down the fascial tube, which, again, some mind-boggling mechanisms of things we think we can do with our hands. But anyway, and then I'm checking in. Hey, as we're doing this, patient, I've been doing this for about 15, 20 seconds. As I'm doing this, does the sensitivity of this area feel like it's staying the same or changing at all? If it's changing, boom, let's go. I might go even a little further, see if we can really get it moving and get things loose. And then, again, test, treat, retest, get them up, stand. And if was that painful thing important? But again, it's the supporting cast. Usually that's visit 2. I do tend to do more active movement-based modulation of pain on visit 1, just so they can start owning symptom change right out of the gate. Of course, sometimes I jump in with some manual if they're having troubles getting things moving or various reasons. But Yeah, I think just understanding that painful manual therapy is related to some mechanisms existing in the human that can modulate a pain experience. Use them wisely and in a non-sadistic fashion, I think is a probably a good tip for folks as far as it's maybe okay to bump into some stuff, especially we're asking patients to bump into pain with exercise oftentimes, and usually that's what's necessary. Ben Smith's work talks about painful, having people allowed to work in a pain with exercise. Does that help? Yeah, it does. They tend to do better than the folks that are given this pain contingent, don't move unless it's not painful. So I think there's some value of maybe bumping into it with a little bit of manual therapy movement. What are your thoughts with that, Jared?
Well, yeah, I kind of wanted to circle back around to how, I where coming out of school, I was, you know, hurt people essentially. Do whatever it takes, be as aggressive as you need to be, stretch it as hard as you need to stretch it. And then my pendulum swung way over to, oh man, I'm not going to do anything painful with manual therapy because I'm just reinforcing pain and I'm just, making somebody worse. And manual therapy is not doing any of these things that I thought that it was doing. So I need to be as gentle as possible to where now I like to think of myself as a little bit more in the middle, where I'm not going to be sadistic towards people and have these unfounded thought processes around how manual therapy works, where I'm just cramming on people's tissues. But at the same time, if we're having a narrative in clinic that pain doesn't mean damage and that pain is okay to bump into, and I want to test how well somebody's, conditioned pain modulation and, endogenous mechanisms are working, I think it's okay to press into a little bit of discomfort, to press into a little bit of mild pain, to kind of see how a person's body responds. How irritable is this? How long does that irritability last? Does gradual exposure actually make it better? Does gradual exposure actually make it worse? What can I talk to that person through this little bit of an experience of pain and say, hey, like this is going on. I'm giving you a little bit of pressure. This clearly isn't doing any damage. We know that you've deadlifted 50 pounds and like this isn't nearly as much force as that. It's just really specific. And, I think that you have a pretty sensitive area right there. And we can talk about the neurobiology and we can talk about like the pain science, explanation when I'm doing that manual therapy and help them wrap their head around, hey, I've got this area in my low back that is sensitive to this type of movement. And he's exposing me to this type of movement. And that's actually a good thing because it's building my tolerance to it. It's like the exposure to the sun and the sunburn. It's like the exposure to stress on the hands and the callus building. It's changing the narrative completely and allowing people to be comfortable exploring that, but not cramming through something that is making them significantly work and causes them to be out of commission for a day or two afterwards.
Yeah, no, it's patient-centered care. It's not like this is my theory. I ram people down this theory without any. And I know people are not considering, but this is where test, retest, treat. You're seeing, hey, if I'm going to engage in this, I'm going to do it thoughtfully and with very much looking at what's happening as I'm doing this. And like Jared nicely pointed out, a good explanation during, before, during, and after to just really come alongside somebody as you're nudging into this stuff. Same thing as I would do with exercise, and then just kind of test response and see, not just like blast through 30 minutes of painful stuff without any check. Hey, patient, how you doing? Just yeah, or hey, this just has got to hurt to help. I mean, you should be seeing if you're seeing objective asterisks and subjective movements starting to decline and degrade as you're doing this stuff. You should be thinking twice, like, am I helping this situation or am I hindering it? But I've had patients where too, like, a nice healing process can get disrupted nicely by folks just feeling like they need to blast in there. Like I still am baffled at the thought that a whiplash, where you have a violent soft tissue load and strain, and often, if you look at the research, there's quite a bit of soft tissue disruption and injury when they do postmortem studies for unfortunate folks that don't come out the other side. Why would you go in there and refund that sucker with a painful manip or blast it with stuff? It just still doesn't make any logical sense to me. But again, dumping pain into some system with a therapeutic narrative and some claim of necessity to a patient, I think, can get somebody to have a positive response to it. Is it founding in science and reality? I don't think so. I mean, I don't know what, and if I'm happy to be wrong on this, shoot me research, message me. I'm happy to see why on God's earth you would want to blast pain into an acutely healing situation like aggressively. Like that just still doesn't make any sense to me. But I think hopefully we've given you reason to kind of consider how and when and why you might use, some techniques and treatments that produce some discomfort or pain, and even might reproduce the patient's pain, because that is okay. Hopefully, what you've heard with Jarod and I today, it's just doing it judiciously in a patient-centered way with a good thought process behind it, where you're testing it, you're treating if you use that, and then you retest, and then you're really assessing, hey, patient, what did you think? This cognition targeted, manual therapy that we talk about at Modern Pain Care, where you're really getting a good understanding of what the patient's perceptions, beliefs, expectations are, what their perceptions, expectations, beliefs are as you're doing the technique, and then afterwards, so you can really maximize that encounter when you're putting some of these techniques on people, and hopefully moving them in a positive direction. But instead of just ramming people into painful techniques, we're doing it more in a very individualized N=1, tailoring it to the unique response of that individual versus this is what I do, this is what my certification tells me to do, and I just do it without a thoughtful process behind it. Anything you want to leave folks with before we finish up today, Jarod?
No, I would just say if you want to dig deeper on this, we can definitely dig a lot deeper, and let us know, comment on this, let us know that you want us to take a deeper dive into it. We can pull in some other people like Matt Lowe. He's got a brilliant framework when it comes to manual therapy and allowing pain and certain levels of aggressiveness in manual therapy when it's very person centered and very patient specific. And we've got some coursework from Matt Lowe on the Lifelong Learning Academy that I think hits home on this particular topic. If anybody wanted to learn a little bit more about it or read some of the work that he's published as well.
Yeah, Matt has probably been one of my better influences on that, definitely, as far as like I also initially kind of just would pull away from manual or anything painful when I first got into this, because oh god, do we want to even create pain with people? I think there's a context and a situation where you can create with a patient where it's a helpful way to move them forward, especially when you show them that nudging into pain may be something that actually helps the situation, and you frame it as such and let the patient unpack that with some Socratic dialogue where they start talking and exploring that versus us cramming that narrative down their throats. But that's a whole another podcast for how we educate and let patients do more experiential learning versus pain-splaining people things, where they can start unpacking some of these concepts with context we create in the clinic. But hopefully that was helpful for everybody, and definitely reach out to us. There's actually a discussion on our Lifelong Learning Academy. It's a free discussion. We have a free forums discussion area where you can jump in some of the discussions and things we have. I'll link it in the show notes below so you can check it out. We did have a discussion on this with some good clinicians who jumped in and kind of put their thoughts, and I thought it was great. Saw some good discussions and some thoughtful approaches that people are using out there in the clinic. So definitely jump on that. Also, if you're having troubles figuring out how to figure this stuff out in the clinic and you're just like, oh my god, I don't know what hurts, what shouldn't, like where do I do, and all this stuff, feel free to reach out to Jarod and I. We're in the process of helping some clinicians right now. We got our coaching mentorship program that we just rolled out. I'm excited, just got our first folks rolling in it, and excited to start getting those folks results in their practice, and hopefully not running through the same struggles and failures that Jarod and I did as we rolled through our career. So if you need any help and you're looking for some more individualized attention, don't hesitate to reach out to Jarod and I, and we're happy to have a chat with you and see if it's a good fit for you. But definitely we'll be sharing content with you to help you through your journey regardless. And hopefully you all enjoyed today's episode, and we will talk to you next time.